Good afternoon and welcome everyone. Thank you for taking the time to participate in today's live webinar, What's a Palliative Care Philosophy? We are so pleased to have a very special guest speaker who will guide us through a presentation and case studies on this important topic and its effect on people living in long-term care. Please note that this session is being recorded for educational purposes and will be made available on our website. Before we start, I wanted to review a few housekeeping announcements. You'll notice that all participants are in listen-only mode. We've muted audio in an effort to eliminate background noise and distractions for our speaker. We have protected time for an interactive question and answer period at the end of today's webinar, at which time we'll invite you to type your questions into the question and answer box. Before I introduce our guest, I invite you to complete a quick poll that will appear on your screen to help us understand the current understanding of our participants about the palliative care philosophy. So we'll just give you some time, some 30 seconds to answer the question. The options are palliative care philosophy refers only to end of life or comfort care. Next option is it involves quality of life and personal care goals. And the last option, I don't understand it. So we see the results coming in. Okay, we have about half of our participants have responded. So I think we can close the poll and the results are up on your screen. It looks like 82% of those who responded understand the palliative care philosophy to be something that involves quality of life and personal care goals. We have 9% and 9% have chosen the other two options, so refers only to end of life and comfort care, or I don't understand. So we will see by the end of this presentation if what the answer is. So without further delay, I'd like to give a warm welcome to our guest, Dr. Fred Mather. Dr. Fred Mather is the medical director at Sunnyside Home, which is the municipal home for the region of Waterloo, and also serves as an attending physician for 2 Rivera Living homes. Dr. Mather is the past president of the Ontario Long-Term Care Clinicians, and he chaired the FLTCA Conference Planning Committee for several years. He is the past chair of the Care of the Elderly Committee on the College of Family Physicians of Canada. In addition, Dr. Mather is currently the vice president of OARC's board of directors. And with that, we'll hand it over to you, Dr. Fred. Thank you so much.
Thank you, Stephanie. And it's my pleasure to speak here on the palliative philosophy or the palliative approach to care in long-term care. Something that I'm actually pleased to see included in the new legislation, and recognize fully that it's maybe created some terror in some people because of the association of palliative care with end-of-life care. And one of the outcomes of today's topic will be to make that distinction. Over the last decade, I've been more involved in long-term care on a provincial level by being on the executive, serving as president and past president of the Ontario Long-Term Care Clinicians. We represent the physicians who practice in long-term care. Our membership also includes nurse practitioners and pharmacists. Our vision is that all Ontarians in long-term care will receive excellent care. And our mission is through advocacy and education. For education, we offer the largest conference in Canada for long-term care clinicians that comes up in October every year. And over the last decade, we've developed the medical director curriculum. And another new change in the Fixing Long-Term Care Home Act is that the medical director course is now mandatory for all medical directors in long-term care. And I will refer shortly to how we are including the materials on the palliative philosophy of care in the medical director curriculum. So looking ahead over the next hour, I'm going to give you an overview of modes of healthcare. We will explore two definitions of palliative care. First, the World Health Organization, and then a more expanded one that we've developed at the Ontario Long-Term Care Clinicians. I will explain why the palliative care philosophy is important to residents and clinicians. And most importantly, I want to share the importance of this palliative philosophy of care with resident stories, exploring how goals of care will differ. I will plan on leaving 10 minutes or so at the end to answer questions. We also were discussing beforehand, if there were questions unanswered, we could probably provide answers in a frequently asked questions sheet at after this session. To help understand where the palliative approach or the palliative philosophy of care fits into healthcare in general, I break it down into the 4 quadrants that you see on the screen there. Acute care or interventional care is what a lot of people view medical care being. That's the stuff that's done in the hospital and in the emergency room. And the reason why shows such as Grey's Anatomy, House, and ER are so popular. Although I would suggest that when you look at how we receive our health care, whether we're parents or children or living in the community as an older individual or in long-term care, that aspect of care is just a small part of our healthcare system. It is, however, a big part of where a lot of us get our training and where the mindset of many physicians may be. I had a younger colleague take over my family practice 5 years ago now. However, when I look back at the decades that I spent as a family physician, in addition to doing long-term care, a lot of that time are on the 2 squares on the right-hand side: prevention, blood pressure checks, checking people's lipids, providing health counseling, all the cancer screening that we do, immunizations, and more. A very important part of our healthcare system. And also the chronic disease management, the regular visits of people with high blood pressure, diabetes, arthritis, and all those conditions that we monitor and treat to optimize quality of life. Now, the palliative approach or philosophy of care encompasses all those things, but I'm going to show how it is distinct from the fix-it approach, which is acute care and prevention and chronic disease management, although it includes all of those aspects. Why is it important to have this palliative philosophy or approach to quality of care? And it's about quality of life. And it's a process that begins at the time a resident moves into long-term care, or preferably before. Time doesn't allow me to share all the resident stories that I would like, but I have a couple of individuals, one from the Mayo Clinic with Parkinson's disease that had palliative counseling right at the time of diagnosis. Another from the work that I do in the memory clinics. I do a memory clinic 3 days a month, of how we begin the palliative approach to care as soon as we recognize that there may be a cognitive impairment of some sort. So it's an organic, dynamic process that spans most life-threatening and chronic illnesses. The second point is that if we don't say we're doing the palliative approach to care in long-term care and promoting a good quality of life, people who are unfamiliar with the work that we do might just say it's not being done. And we observed that during the COVID pandemic. The schema there with the 5 different, well, the 1 diamond and the 4 triangles is a common depiction of describing the palliative approach to care, taking that purple center diamond, which is symptom management and supportive care. On the left-hand side, there's cure and there's control of disease. And as conditions progress more into the latter end, as one approaches end of life, it's more survivorship and hospice-related care. In December, the Fixing Long-Term Care Act, or Bill 37, was passed by the government of the day that will continue as the government, and it received royal assent on April the 11th. And in the act is embedded the principle of the palliative philosophy of care. Of particular note to you, the resident in long-term care, number 25 on the Residents' Bill of Rights states that every resident has the right to be provided with care and services based on a palliative care philosophy. Elsewhere in the legislation, it refers to all the aspects of care provided in long-term care: medical, nursing, personal support, mental health, nutritional, dietary, recreational, social, palliative, restorative, religious, and spiritual care. That is treating the whole person. And it is the responsibility to ensure that the long-term care provides care services that integrate a palliative care philosophy. And this is described more in the regulations of the Act, which calls for the residents being given an explanation of the palliative care options that may be integrated into care that is arranged and carried out to the resident, including but not limited to end-of-life care. And to break it down a bit more on the final note on this slide, it includes quality of life improvements, symptom management, psychosocial supports, and end-of-life care. Let's look at some definitions for what the palliative care means. But before we go to the definitions, just one more slide here on why it is important. Having a palliative care philosophy embedded in the Residents' Bill of Rights is important, because if it's not there, people think it's not being provided or not part of the scope of life in long-term care. People don't move into long-term care simply to die. They continue to live rich and full lives. It is essential to recognize this. Having a prevailing philosophy of the palliative approach helps clinicians and caregivers, because it allows us to better understand and meet the residents' needs and goals. This philosophy gives a more anticipatory or holistic view of the person. Finally, we have changed our philosophy of care. We're looking at the goals of care differently, more on the quality of life focus. And I will give examples of how individual goals of care are so important for each resident. And I often say that there's approximately 75,000 residents in Ontario long-term care homes, and there's 75,000 different goals of care. It's all based on the individual's beliefs and wishes. So let's look at a couple of definitions of what palliative care or the palliative care philosophy means. The World Health Organization defines palliative care as an approach that improves the quality of life of patients and their families facing problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, be they physical, psychosocial, and spiritual. At the Ontario Long-Term Care Clinicians, we have expanded on the definition of the palliative care philosophy and have tailored it to be especially particular to individuals who reside in long-term care. A palliative philosophy supports individual quality of life through a continuum of care delivered alongside curative measures and throughout chronic illness. It acknowledges and responds to all aspects of humanity, not just medical considerations, but also physical, psychosocial, cultural, emotional, and spiritual needs. Each individual's approach to care is based on conversations to better understand the personal goals of care based on their values, cultures, and preferences. The palliative approach to care understands the uniqueness of each individual, their personal history, experiences, spiritual identity, cultural norms, and the vital interpersonal relationships that bring meaning to the whole person. It aims to maximize quality of life by mitigating all aspects of suffering through identification and anticipation of problems, including but not limited to natural aging, disease progression, pain, loneliness, interruption of familiar patterns of living, and loss of identity that accompanies moving into a long-term care home. It requires the understanding of everyone involved in caring for long-term care residents. The conversation begins ideally before admission. The palliative approach to care influences every opportunity for individuals to experience quality of life during their long-term care journey, but it does not exclude, and it obviously includes end-of-life approaches. The palliative approach assures individuals appropriate, compassionate, and dignified end-of-life care. So I'd like to apply these definitions of the palliative philosophy of care to 3 resident stories. And we'll start with Courtney. And Courtney is 36 years old. She was in a serious car accident 10 years ago. Her lasting impairments are from a fracture to the lower spine and head injury. She has hemiplegia. She's paralyzed in the lower half of her body, and expressive dysphasia. An expressive dysphasia causes significant word-finding problems. Her cognition is otherwise good. She will have moments of emotional or mood difficulties, probably related to the brain injury that she received. Before moving into long-term care, Courtney completed several months in rehabilitation. She relies on a power wheelchair for mobility. The speech and language pathologist continues to follow her. She effectively uses her text-to-voice application on her tablet for most conversations. And on a lovely sunny day like we're having right now, it would be hard to find Courtney because she may be outside in the shade of a tree reading on her e-reader or at the nearby mall getting some treats or personal care items. Courtney is determined to have a full and purposeful life in long-term care. Her 2 children, who were preschoolers at the time of her accident, are now teenagers. She looks forward to being a grandmother. Her perseverance to survive and thrive will be her legacy. She's had issues in long-term care. She's had serious life-threatening blood infections among them. This is related to urinary tract problems caused by her spinal cord injury. And therefore, her goals of care includes prompt treatment of symptomatic urinary tract infections with antibiotics. And past experience has found that she needs intravenous antibiotics. Therefore, if the NLOT nurse, the nurse-led outreach team nurse, who is a nurse practitioner, is not available to start an intravenous, she wants to be sent to the hospital immediately. So in looking after Courtney, we're not going to fix the damage to the left parietal lobe that causes her speech and mood issues, nor, although she's read about stem cell treatments and electrostimulator or implants, it's unlikely that she's going to have any recovery of her spinal cord injury. She still wants us to be prepared and provide anticipatory care for any crisis that occur in the future. Otherwise, she plans to live a full and meaningful life in long-term care. Let me introduce you to another resident who is 76 years old, James, who likes to be called Jimmy by the staff who looks after him. He has severe heart disease. In the past, he had coronary artery bypass surgery, and now he has a pacemaker. Along with other ailments, he gets very short of breath. To look at him in his chair or lying in his bed, you wouldn't think that a task such as getting up and going to the washroom would cause him so much breathlessness. The doctors tell him he has stage 4 heart failure. He develops wet lungs, or what the doctors refer to as pulmonary edema. On James' last visit to the emergency department, he had severe pulmonary edema caused by a small heart attack and was further complicated by a life-threatening heart arrhythmia that was a fibrillation requiring the paddles or the defibrillators to restore his heart rhythm and save his life. The hospital doctors told him that he was lucky to live, and it is very unlikely he would survive another episode like this. They recommended a do not resuscitate or DNR order and be palliative care at the nursing home. James, I might add, that is advising his residence council that the home should have an automatic external defibrillator or an AED available. James had a recent visit from his grandson who informed him that his wife is expecting in 4.5 months. And they know already that they're going to have a boy. James shakes his head in disbelief that they know this already. The expectation of a first great-grandchild is a long time coming. The new parents have already chosen a middle name of Robert, which continues a tradition into the 5th generation. James realizes his precious prognosis. He does not want to change his goals of care at this time. He wants to wait until his great-grandson is born. His goals will include resuscitation and transfer to hospital. He tells the interdisciplinary team in long-term care that he will reassess his goals again in 5 or 6 months' time. So James is someone who recognizes that he has a limited life expectancy, and something like a DNR order might be very appropriate for many people like him, but he has a reason for the care team to work to keep him alive and optimal until his great-grandson is born. From a physician point of view, I would make sure he has all the right medications for stage 4 congestive heart failure, ACE inhibitor, beta blocker, diuretics, etc. And it's going to require maybe a bit more monitoring in the months ahead, because he also has some kidney failure as well, and we need to check his potassium in that. But we do have clear goals of care for the months ahead. Finally, I would like you to meet Sunita. Sunita is 91 years old and has been independent since her husband, a retired surgeon, died 9 years ago. With some forgetfulness, she was recently diagnosed with Alzheimer's disease. A bad fall 4 months ago resulted in fractures to both her hip and her shoulder, just below the shoulder in the upper arm. After surgery for these fractures, she was discharged from the orthopedic unit at the hospital to the convalescent care unit in long-term care. Her plan was to return home within 3 months of the restoration and rehabilitation provided to her in long-term care. Although she had a delirium following her surgery, it cleared. She continues to require some cueing to perform basic activities of daily living, such as dressing, toileting, and bathing. She uses a walker and fears another fall. While in convalescent care, she found that she enjoys the activities and the socialization in the long-term care setting and took an opportunity to move in. Sunita remains capable to make health and personal care decisions. Following the death of her husband, she experienced several more losses over the past decade. She has had a good life. She is asked about her wishes and values. Giving a wistful glance upwards and parroting her husband, she says, "I'm on call." Her son, who is a doctor in Calgary, joins virtually the Admission Care Conference. He confirms his mother's wishes for pain and symptom management, preservation of dignity, and, when the time comes, be allowed a natural death. So Sunita's goals are quite clearly to have good pain and symptom control for whatever may lay ahead in her illness trajectory. She wants to preserve her dignity. She does not wish to go to hospital. She's had enough experience in hospital. And when the times comes, be allowed a natural death. So with those cases in mind, you're provided with an example of how individual goals of care vary with each individual. Goals of care is part of advanced care planning, and I will show this shortly. Returning now to what the legislation says about the palliative philosophy of care, what can residents expect to see? The addition of your new residence right likely won't result in big changes in practice. I've been doing this work since I started practice over 40 years ago, and I've always said that our palliative approach to care begins for most of our residents on the moment they're admitted. However, their goals of care may vary greatly. It will remain important that residents are included in ongoing conversations about care planning. And it is important to make your wishes and goals known to your team and to the loved ones. This schema here with advanced care planning, goals of care, and consent comes from Hospice Palliative Care Ontario and is part of the Speak Up resources for advanced care planning. Advanced care planning is the larger conversation we all should have with our health providers. It's not exclusive for long-term care. It applies to individuals that I would see in my office at a family physician. And really it applies to all of us as we look ahead to possible health issues we might have in the future. It's a conversation to share with families and friends so they know what your choices are should it ever be a case where you cannot decide for yourself. It's a way of showing us what our preferences are, giving important parts of our personal past histories, sharing our values and beliefs. Goals of care is more specific. These are the discussions in the context of a current illness about a person's values and goals leading up to a treatment care decision. Courtney, for example, became very sick from a kidney infection that got into the bloodstream, and she almost died of sepsis. So her goals of care is that if it were to happen again, that she gets the most prompt treatment to prevent a life-threatening situation. Sunita's goals of care is to be treated in a relatively non-interventional way to assure her greatest comfort. And at the bottom of this is consent for treatment and care, or care. And the important thing here is that with every treatment or diagnostic decision, there should be consent and review as to whether this fits into your goals of care or how you might want to change your goals of care. The whole principle of consent is what's key to any decision, and consent is time specific. It needs to be given at the time when a test may be ordered or a treatment given. It may often be implied. If I'm following you for diabetes, for example, I may want to do a A1C every 3 months, and you expect that. Or it may be another conversation altogether. One may have a serious pneumonia, and there's the discussion whether it'll be treated in the long-term care setting or if there should be a transfer to the hospital. Consent is time-specific. It's also task-specific, and in that each situation may be a little bit different. Sometimes decisions need to be made in a hurry, and that's, again, goes back to where an active knowledge of your goals of care is important. This is a cartoon that was in a recent article in one of the oncology journals, but it shows how the palliative approach to care is a way of being prepared to anticipate future needs. In the upper panel, there's a couple just being discussed too about the palliative approach to care, and they're being offered an umbrella, and they don't think they need it at that time. And then a few months later, they're caught in the rainstorm, and the clinician that they were talking to is after them with an umbrella, saying, "Here, this will help." And she's saying, "Thank you, I wish we had got one earlier." And in the bottom panel, they're taking the umbrella, and then they're caught in a rainstorm, and they are protected. The final panel says, "So glad we had it when we needed it." This illustrates that the palliative approach to care is to be prepared, to provide, as the WHO definition says, that impeccable assessment when it's necessary, or as the OLTCC definition says, to assure the best quality of life by considering all aspects of humanity. Here are some tips for making your goals and wishes known. You are the most important person in long-term care, and you are the best advocate for your needs and wishes. So it's important that you are included in the conversation. As the saying goes, nothing about you without you. And it's something that I think all residents and their families need to be mindful of. I do observe that often when someone's being admitted into long-term care, they may be overlooked because there's that diagnosis of confusion or Alzheimer's disease on the admission documentation, which should have no bearing whatsoever on the individual's right to make decisions pending that there be some assessment of their capacity to do so. And even then, they should be included. Ensure that you are included in ongoing conversations about your care, from move-in to care conferences, etc. And as I'm sure you're aware, there's a care conference that's mandated in the first 6 weeks of moving into long-term care, and an annual care conference after that time. You can also request a care conference with the relevant members of your care team whenever you want. And if you want to contribute something to get more from your care conference, ask that you define what your goals of care are. And think of the different goals of care that apply to Courtney, James, and Sunita. Make a list of what's important to you. Share with people of importance to you, physicians and care partners. How important is it to you if you're in a life-threatening situation, if you get transferred to the hospital? You may not want cardiopulmonary resuscitation for very good reasons, but that doesn't mean that you do not want reversible conditions, such as a stroke, which could be limited by thrombolytic therapy, or in Jimmy's case, severe pulmonary edema that could be helped by defibrillation and diuretics. You can make it clear what you want or what you don't want. Engage a substitute decision maker to advocate for you when you are no longer capable of speaking for yourself. Where I am right now in our home in the region of Waterloo, we've just developed an advanced care planning package, which we give to residents and families prior to admission, saying consent is a conversation. And in a very simplified form, which is a starting point, we basically ask 3 questions. If it comes to a situation where you cannot make your own healthcare decisions, who do you wish to decide for you? The second question is, if my heart stops, do I want CPR to be resuscitated? And finally, the third question is, if my condition worsens, where do I want to be looked after? Options possibly being staying in long-term care, being in a hospice unit, long-term care, being in hospital, or maybe in a hospice setting, if possible. Ask to see a copy of your plan of care and review its contents with a trusted team member. Finally, remember, it's your life, your wishes, okay to change your mind. And that's the important thing about goals of care. You can always change them. If James did not know about his great-grandson coming in 4.5 months, he might have followed the advice to go for a do not resuscitate order. However, in his case, he has a reason to hold on, if possible, for another 4.5 months. So let me, before we go to the poll question, just conclude by going back to why the palliative philosophy of care, or the palliative approach to care, is important for residents and care providers clinicians like myself in long-term care. First, it is an organic process that should begin at admission, ideally before admission, and continue throughout the long-term care stay, where there's that continuous opportunity to revise and update goals of care. The second is that it's about assuring the best quality of life for people who move into long-term care. And if they are approaching end-of-life care or develop more serious illnesses along the way, they're provided with the best pain and symptom management. If we don't say it's being done, it may be inferred that it's not being done. Jennifer, can I turn it over you, or Stephanie, turn it over to you now for the final poll question?
Absolutely. So if everyone could just turn to their screen and help us with the final poll question. How do you feel now that you've received a bit more education about what the palliative care philosophy means? So the first option is I have a better understanding. And the second option, I need more information to have a better understanding. So we'll keep it open for a few more seconds. We've got about half of our participants who have responded. Okay, the responses have slowed down, so we can end the poll. We have 96% of those who responded saying that yes, they have a better understanding, and 4% of those who have responded saying that they need more information. So it's always good to keep an open mind and keep searching for information, even when you do have a good understanding of the topics. Thank you for that. Okay, we'll just close the poll. And Dr. Mather, we do have some questions that have come in. One of them is about sharing the advanced care planning guide that, that you've sent out to families or that you recommend be used with families.
Okay. Our guide is called Consent is a Conversation. And I've actually just had some emails back and forth with a social worker who's working on it. It's being revised along the way. So I would be pleased to share it. I will wait till at least the end of this week because I know that there's some changes that we've talked about that I will provide the most up-to-date one, and maybe I can find out from the OARC office the best way to share it. There is some controversy to it, and often with these things, there's no right answers. One issue that's come up with the second question, if my heart stops, do I want to be resuscitated? A lot of the guides would say that if resuscitation is requested, it will be performed if there's a witness cardiac arrest, as opposed to someone being found with vital signs absent. And we've been doing some research and advice on that, if that's really a valid thing to put in the document, and that there should maybe be more assessment done when there is an expectation for cardiopulmonary resuscitation.
Yes, that's something that I've heard too in my time in long-term care, that it's only for witnessed events.
Yep.
Thank you for that. Our question and answer box is open. So if there is anyone who'd like to pose a question, the floor is yours.
Stephanie and Dr. Mather, it's Melissa here.
Yes.
We did receive a question in advance of our session that I was hoping to share live. And this question is, does the palliative care philosophy in long-term care include MAID, medical assistance in dying?
Okay, thanks, Melissa. And I'm going to step back a little bit there and challenge some of the information that's been presented and the response to including language about the palliative philosophy of care in the current legislation. It's been stated loud and clear that residents don't come into long-term care to die. And I hope that in the examples I gave, and I think it's true for the vast majority of residents in long-term care, they come in to lead full and purposeful life. Often, as in the case of Sunita, a more meaningful life than she had when she was living on her own at home prior to her fall. There are exceptions, though, of people who come into long-term care. One is hospice patients, that their admission to hospice is because they have end-of-life diagnosis, usually a cancer, and they're in hospice care, although the guidelines for the hospice gives a 3-month or 4-month prognosis, and things have turned out better, or they've survived longer than expected, and it's felt that hospice is no longer appropriate for them, and they come into long-term care with the same goals of care as they had in hospice. So we are looking at an admission to that with end-of-life care. Since the original MAID legislation was passed in 2016 and then updated earlier last year with Bill C7 in the Federal House of Commons, we've seen MAID applied more in long-term care. I think it's a more thorough process than when it first started out. There's a better familiarity and comfort with the assessors and providers that work together for that. And we indeed have people coming into long-term care with an end-of-life diagnosis, because some of our hospice care will not accept individuals who may include MAID in their goal of care, whether they're actually going to act on it or not. But that's an option that's been ruled out to them. The current update in the legislation in Bill C7 last year removed the part of the legislation that anticipated death would be fairly immediate, which has broadened its use. What it has not changed, though, is the requirement for consent to be given at the time. And that is one thing that limits the use of MAID if that's what a person wants in long-term care. A lot of individuals have neurocognitive impairment. They have chronic confusion, as in dementia, and you can have dementia with other conditions such as Parkinson's disease, for example, and they cannot give an advance directive that that's what they want. That's where the controversy is going forward, is whether or not individuals may be able to give an advance directive for MAID if that's what their wish is. Melissa, I hope that covers the question that was
Thank you
asked.
very much. That's excellent.
Yeah.
Thank you. And it's great to hear you touch on the difference between end-of-life care and the palliative care approach. So you've weaved it into several of your examples and also in answering the MAID question. But if you wanted to just let the participants know here that how end-of-life care is provided in long-term care and how long-term care homes are equipped to provide end-of-life care.
That's a really good question that could have actually quite a long answer to it. One thing that we at the Ontario Long-Term Care clinicians felt that the authors of the new legislation and regulations needed was a definition of end of life. So let me start with that. And this is what we have provided in terms of end of life, as describing it as the final period in an individual's illness trajectory when it becomes medically obvious that death is imminent, often measured in hours, days, or weeks. As the systems of the body begin to shut down, common symptoms include drowsiness, confusion, progressive weakness, and decreased level of consciousness. There is a loss of thirst and appetite and a reduced need for food and fluids. Late signs include monitoring and cooling of the extremities and a change in breathing patterns. Goals of care are for pain and symptom management rather than any life-sustaining treatments. When someone approaches that in long-term care, and these really became more, I wouldn't say the standard, but close to it, the commonplace during the some of the horrific COVID outbreaks in waves 1 and 2. There's order sets that ensure that all the necessary pain and symptom measures are there. At OLTCC, we provide workshops and webinars on palliative care, and that's basically driven by what participants request in their evaluations year after year. A full day workshop is provided for the LEAP Palliative Care program, which more and more nurses and physicians in long-term care are taking again, because it's a field that is changing, is improving all the time. With the new legislation, I referred earlier to the medical director course and the medical director curriculum. We're introducing a chapter on the whole palliative philosophy of care, which also addresses the end of life requirements that are present in the new legislation and regulations. We also have availability for palliative care consultation, more so than ever before, particularly e-consults, which can help with some of the more challenging problems that may occur in severe symptom control or end-of-life situations. And I must say, in terms of the palliative care consultants that are there to assist us in long-term care, it's not just about end-of-life care. It's not just about dying. They can be a great resource for individuals who, for example, have severe neuropathy and maybe a history of an opioid use disorder, and you're just not sure what the best approach to their pain and symptom management are. And also, and this is often very effectively done by my palliative care colleagues in the hospital, they will assist us in the conversation about goals of care. And they give us an opinion, or they give, more importantly, the resident and their families an opinion as to what to expect in terms of a prognosis and the best care that can be offered.
Thank you, Dr.
One question I had beforehand, and I meant to just touch on it in the introduction, and I didn't, was that why did I go into long-term care work? And when I thought of an answer, I go back a long way into my childhood. I grew up in a small town in Eastern Ontario, and often on Sundays, usually with my father, I would visit some relatives and friends of his in what was then called the county home, the mid-20th century equivalent from where I'm at right now, in another municipal home. And I think it's always something that interested me. When I was doing my family medicine residency, I took extra training in geriatric care. In my first practice, they were really interested as to what my interests were. So I quickly became the director of the chronic care unit at the hospital. This is before chronic care reform in the 1990s, and also looked after a small nursing home in a nearby village. The nursing home had issues which helped me understand the issues of compliance and quality better. And back then, the inspectors, they weren't called inspectors then, they were called compliance officers, came in and did their work. Unlike the inspectors now, they were there to assist more. They discussed problems with the staff and the management. And one inspector took an interest in me, and she, probably because I was interested in what their role was, she brought for me one day then the Nursing Home Act, which about 3 or 4 revisions later is now the Long-Term Care Homes Act, and talked to me about compliance and regulations. And that was a very useful learning experience for me, and my interest in this field has sort of grown from that time.
Thank you, Dr. Mather. It is 2:56, just a quick time check. We do have a question that's come through the chat just about MAID again and care planning, spiritual concerns. So an individual who was requesting MAID but was living in a Catholic faith home, how could they access that service and keep in line with their goals of care and their care plan?
I am not a MAID physician, so I'm not on top of all the current practices, but I am familiar with cases like that. And I know that it's just part of the home's policies or principles not to offer MAID for religious reasons. And this probably varies where you are and how accommodating the providers are. But I know examples are that individuals are transferred to hospital where MAID can be performed there. And I know of examples of that, or transferred to another long-term care home, which logistically can often be difficult. In some parts of the province, the hospices do allow for MAID. In other parts, they don't. My understanding is it's largely the beliefs of the palliative care physicians who are working in those hospices that determine what their MAID policy is.
Thank you so much. So it is 2:58. And Dr. Mather, I wanted to thank you so much for your expertise and for your time this afternoon. So while many of us did have an understanding of what the palliative care philosophy was and have witnessed it and been involved with it and the approaches that you've described in their homes, it's great to have you highlight the importance of explicitly stating that this is happening through the Resident Bill of Rights. It's something that residents and families can expect and look forward to now that it's explicitly stated in those rights. To our participants, thank you for your thoughtful questions and your participation this afternoon. Please remember that a recording will be available on the OARC website. As always, we are encouraged and inspired by your feedback, so we invite you to complete the post-webinar evaluation, which will pop up on your screen, and help OARC identify future learning needs and opportunities. Stay safe and stay well. Thank you.